and how bad it was. They rupture the, the macular and has blood underneath the retina. It was a terrible complication. And I believe these complications happened just because I was in a high pressure, intraocular pressure, and I opened this fluid, and the jet stream, the first jet stream, touched the retina and make this big hole, and unfortunately it was in the macular area. But we have to sometimes in this bolus retinal detachment start with low pressure at the beginning. And this one is distracting that's happened when they are finished the case. Everything was very okay. Look, I was just removing the PFO. Was a surgery for remove intraocular lens, and I was removing the last PFO bubble with a positive aspiration. And the last one was a little bit trick, and wow, just sucked the retina. And I just finished the case with laser and gas. But something that we should avoid, make all these complications. This one was distract, and have to be very careful when you remove the PFO, especially the small bubbles, and you should turn the eye and make the bubble goes to the optic nerve and go very slowly, not very aggressive like I did. And I think this is my last case. I will unshare my view. Hudson, it's all yours.
George, I think wonderful cases, but I think you have real guts to show your problems, which is many surgeons are shy to show. And I think it's a great lesson for the both experienced surgeon and beginners how to avoid a complication. You have showed the complication happening, and very nice of you and very modest of you to, with great humility, you are showing your complication. We all know you're a great surgeon. But I think I have a new instrument made by Synergetics, like an ink filler. You can fill the PFCL and then just drop it like an ink filler. I forgot the name of the thing. And the same thing, you can always use the retinal brush to remove the last part of the PFCL bubble instead of using the metal strip. And this is my, whatever, 1
this
cent.
One is from Retinawesome.
I think so. Yes. Yes.
I'm looking for. I think I think many of these cases, if you have more attention, we can avoid. Like the first one, many times you just go there and inject the PFO, but PFO jet stream can be a weapon that can make damage in the retina, and then
Yes.
we have to be very careful with this. And if we just slow down the intraocular pressure and inject in the optic nerve direction and use the light pipe as a way to avoid this jet stream to touch the retina, can fix that. And the second case was I think my first experience with something like that, I just opened the infusion, and the jet stream of the infusion make a hole in the retina. I believe that the pressure was so high, and the retina was almost very close to the entrance of the infusion, and just the first jet stream in the high myopic patient touched the retina and make that big damage. That was terrible to fix. And I always check now if the start the surgery not low pressure, but not more than 30 at the beginning of the surgery. And the last case, I agree with you. We have this very new soft tips can really help to suck the last bubble. That's the worst one. Dr. Jalali, thank you for your comments here in the chat.
Jorge, very interesting cases. You know what I like doing? I like switching the tip from 23 gauge to 25. So I approach the backflash cannula towards the bubble, the PFC bubble, but I don't quite get there. I just put the lumen towards. It's a good technique to switch the diameter to a smaller one and not approach much. But one thing I always tell our residents and the fellows here, and Henrique is one of our fellows is watching this lecture, and we like to use the macular lens for doing that, because after everything is over, some PFOs, some PFC brands, you know, they give you lots of bubbles, and so to avoid these bubbles, and of course they are going to happen sometimes. So I like using the macular lens to remove the bubbles. It works very well because you see you have a great vision.
Dr. Seti asks if the light pipe is gonna break the PFO in many small bubbles like a Fisher egg. No, if you inject continuously and just put in the light pipe as a shield, like not to, you don't need to inject in the light pipe, but just make sure that if you are inadvertently injects too hard, the jet stream will not go like that. And then nowadays I just inject over the optic nerve very slowly, and just that. We don't make the Fisher eggs.
Sir, I have a point. Just wanted to make. PFCL has a very high specific gravity. When you have a small bubble, then you have to stop doing it so that it comes more towards the disc, because that disc, when you aspirate a smaller bubble, it is much safer than on doing it on retina. And the second one is, if you are using a constellation, then you have a IOP compensated infusion. So when you are moving from fluid air exchange to fluid infusion, the pressure in the cavity is zero. So the constellation is pumping the fluid at a much higher rate, which can be very, very risky, because I had a couple of cases where it caused infusion-induced breaks in the retina. So when you are switching on the fluid again, it is always better to hold a light pipe in the anticipated dead stream path, so that you reduce the velocity of the dead stream, so that you can avoid infusion-induced breaks. So these 2 points can help us to manage things better. Of course, wonderful cases.
Very good points. Very good points. I agree.
Sorry, I get a comment. I know that we have residents and fellows here who are following us. When you have a cornea, a not good visualization, sometimes what I like to do is use some triamcinolone to recognize the PF, no PF, so that can help me to recognize and to remove it all. It's a small detail, but I think it's useful when you have no good visualization. Okay.
Good. Thank you.
Very good thoughts. And thank you, Jorge. Awesome cases. And I hope I don't know, maybe you don't have much time left because it's we are almost 9:30 here. And so thank you for your participation. And feel happy to be always with us in our Retinawesome meetings.
Thank you, my friend Hudson, and all my friends here. I hope see you, each one here face to face at Fort Lauderdale very soon, and have good times, and maybe a coffee or beer, and have a good chat. Thank you. Have a good show today. Bye-bye.
Bye, George.
Nice flight. Bye, George. Thank
Nice
you.
flight.
Nice flight.
Thank
Have
you.
a nice flight.
I'm honored to call our keynote speaker, Dr. Subhara Jalali, to present her case. And if you want, Dr. Jalali, I will show your video, but you are now the co-host, and if you want to give us some words, you are free to start. Thank you, Dr. Jalali, our keynote speaker for Retinawesome 14.
Honor and a pleasure to be with residents, fellows, colleagues, and seniors to share some work. So I was told to speak for 12 minutes. That's half a minute for every year of my pediatric retina work, which I started in 1998. Dr. Das, my mentor, saw some spark in me after I had done adult retina work for almost 7 to 8 years. And then I was trained by Dr. Michael Tracy in William Beaumont Hospital in 1998. At that time, the thought was that only very senior professors can do, ROP or pediatric retina surgery. I'm very happy that in the last 24 years, this myth has broken, and a lot of my students here, they're all doing pediatric retina surgery. Even in the first year of their fellowship, they learn and they do. So I want to tell all the fellows here that don't be intimidated. The pediatric retina surgery is a little more tough than the adults, but it has similar principles. And the video that I'm going to show you, it's a little strange video because I have put in clips of videos from my initial surgeries, which I used to do 20 years back when I started. And mainly that is for residents to see how we started. And then we go to few clips. And if you sleep, then you will miss clips because there is no clue to you to know that one surgery is ending and the other is starting. So please be alert and watch the clips, and we go from very basics, few basics, and then some more surgeries, and then surgery in a newborn, and then some of my innovations. So here we go.
This video aims to provide the basic aspects of vitreoretinal surgical techniques in infantile eyes. The first step is to check any area of retinolenticular adhesion that are common in neonatal tractional detachments such as ROP, persistent fetal vasculature, and FEVR. Depress the sclera just behind the limbus, and any adhesive area will show up as a translucent membrane behind the lens. In such cases, do not enter from that area. Enter either into the lens as seen in this case and remove the lens, or have a nasal entry approach as you will see in subsequent video clips. Peripheral vitreoretinal surgery is not possible in the lens sparing mode in neonates. So one can use, let us say, transscleral cryopexy instead of endolaser in this patient with peripheral avascular and unlasered retina. This video is now showing a 23 gauge sutured lens sparing vitrectomy for infantile epiretinal membrane removal using a 23 gauge forceps. Be very careful while lifting the edge by releasing the nasal side of the membrane first. The temporal side will usually be very stiff and taut and have a retinal fold behind due to the elastic stretching of infantile retinas. The traction of temporal edge should be the least to prevent retinal breaks. Once the membrane edge reaches the fovea, be gentle and move in a curvilinear fashion to avoid foveal injury. Do not pull. Successful removal has been achieved of the membrane. This is a bilateral surgery, simultaneous. The other eye of this patient also had FEVR, and here also we have tried not to do just the laser but to do a primary vitrectomy. And the reason for this is again the same, that in this child we want to remove all the vitreous which is causing the traction and not just do a laser, because then the whole life the traction keeps on worsening. So this child presented few days after birth with vitreous hemorrhage, and in this particular eye we were able to create a decent PVD and remove all the vitreous. What I want you to look at carefully is these yellow dots which you are seeing. They seem to be hard exudates, but actually they are in the vitreous. As you will see that as we are removing the posterior highlight, they are just like you would see posterior highlight exudates. So these yellow dots are in the hyaloid and they are not under the retina, so they are not really hard exudates. They look like that. What they constitute, I do not know. I haven't done any histopathology on these, but it seems that there is some material which is stuck to the posterior part of these lesions. So once we tried to remove the lesions, we were only partially successful, and since it started bleeding, then we stopped doing more dissection. You can see more blood has collected from some of. So it takes a lot of time to do the laser, because depending on the zone which is involved in FEVR, there will be a lot of area which is avascular. Always the FEVR will involve either zone 1 or 2. It's almost never seen only in zone 3. So I wanted to depict how to manage the retinal fold and the persistent fetal vascular, which is very often associated with these folds in FEVR cases. So as you can see here, there is some vitreous hemorrhage, active vitreous hemorrhage, and that is the reason why we are operating this case. Many people would have just done a laser, but that doesn't work, because as you will see in the video, there is a lot of vitreous covering that avascular retina. So we are trimming this persistent fetal vasculature stalk, which is going from the disc to the periphery. Near the fovea, there will always be a very dense attachment. You can use a scissors or a bimanual technique, or if you are deft, then you can definitely release that traction slowly around the fovea, as you see here. So there will be a stalk and there will be surrounding vitreous which is causing that fold. Be extremely careful not to eat away that fold of retina and create a disaster. So slow trimming of the stalk, which will relieve the traction which is worsening the fold. We are not going to open that fold, we are not going to do anything to the fold, we are only relieving the traction, so that in future as the eye will grow, it will not create more and more traction and then a regardy. This video is of a 2-year-old child who has retinal hematoma with epiretinal membrane. So we do a core vitrectomy and try to look at the areas where we can find a edge where we can lift the epiretinal membrane. So here we are seeing now that there is a vitreous membrane adhesion. We found the edge, and there was a good edge here. You can see the ERM is between the drag disc and the fovea and the surrounding macular area. We are now using sequentially the end gripping forceps and the vitrector to lift and create a plane between the membrane and the underlying hematoma and the retina. Usually the membrane does come out quite pretty well easily. It's not very adherent, but there would be retinal folds under that membrane, and that is what we have to be very careful about. So the retina would be thrown into undulating folds under the membrane, and we should be very careful. But otherwise, as you saw, it does come out pretty easily. One day post Avastin, a disaster, a macula off, retinal detachment, rhegmatogenous. What have I created and how do I salvage? A very limited core vitrectomy, just ILM peeling around that, break, laser and put oil and remove the oil within 7 days. Today I would do the same surgery with fibrin glue assisted and not put oil. It's such a great pleasure to share my work on scleral imbrication with buccal for combined pediatric retinal detachments. This would include any detachment which has falciform folds, exudation along with a rhegmatogenous component, and these are very complicated conditions where we don't have very good solutions of how to tackle these disorders, and I will be sharing some things that we've been doing over the last 1 year during the lockdown period in this field. So, for retinopathy of prematurity or similar disorders, what does one do when the eye develops retinal detachment some years later? For example, a child like this, where we've done a very good lens sparing vitrectomy, there'll always be a lot of vitreous and traction there, and if they develop a rhegmatogenous component. So I discussed with Dr. Gopal, Lingam Gopal, and before my first case, and he informed that he usually does something called scleral imbrication. And after I did my first case, Dr. Mahesh and Mugam also shared his video on this condition. So here we have a patient who has a rhegmatogenous detachment, traction, some exudation, case of FEVR. The retina is so thin in the periphery that if you start doing vitrectomy and silicone oil, you'll take maybe a couple of hours and still don't know where you will reach. If you do only buccal, most probably these eyes don't do very well because they also have a rhegma with traction. So the success rate has not been very high when I have been doing these surgeries over the last 20 years, and it's not been a very good outcome. So going to the history or the previous things, scleral imbrication for rhegmatogenous retinal detachment was one of the most commonly performed procedure in Oregon Medical School in 1950s. And they reported for that 4/5 of their patients with large tears and bullous detachments actually did well. And what they did was cut down on the sclera, tight the sutures there, and then flatten the globe. And that somehow, amazingly, hard to believe that these eyes, attached. More recently, there have been reports of scleral imbrication without dissection along with vitrectomy for myopic schisis, and some other reports of myopic retinal detachments being treated with scleral imbrication. So this is my technique. You clean the sclera and then make horizontal incisions, and how I have modified it, that I make vertical incisions in the quadrant and do a good dissection where we are able to get good quality flaps, both anterior and posterior. Usually I make it at the equator, but depending on the site of traction, it could be made little more anterior or posterior. And I usually don't do a lot of cautery on the surface, but if it is bleeding a lot, then you can do light cautery. I don't want to do too much of cautery. So once these flaps are made, then use a non-absorbable suture like 50 Ethibond or 50 Dacron, and one has to be very careful when passing these sutures, especially in pediatric eyes, because the space is little, so you have to tilt the needle in order that it doesn't poke the underlying sclera choroid. So when you're trying to tighten, it seems that it will not tighten, but I was very surprised that once you do this scleral dissection, the globe actually becomes very soft. And you come to know how much of the scleral rigidity is helping the globe to maintain its shape, and you can see that we can really tighten it a lot. And so this is it, and you just do this, and you can do this in 1 quadrant, 2 quadrants, all 4 quadrants, depending on the configuration. Along with that, we can also do drainage, and you can do a cut down, or you can do a needle drainage with a 26 gauge needle, whatever you like. And here we have this combined case. I usually like to suture if I have done a cut down, because I'm going to put a buccal on this. So this is the modification that I have done, that most of the reports of scleral imbrication don't talk about covering it with a buccal. So I like to put a buccal which could be a 42 band or just a 240 band, or as in this case, because
there was a very large traction, as you saw in the periphery, and I was not sure where the break is, so I have put 287 in 3 quadrants in this particular eye, so you can put in 1 quadrant or more, and then put the sutures for the buccal. But I was, so happy to see that just with the buccal and skill imbrication and external drainage, I was able to attach this retina. And I also did little cryo in the area of exudation, a very minimal cryo, light cryo, so that the traction doesn't increase. And you can see the buccal really goes posterior, supports that area of folds and maybe an underlying break, or it isolates the break. Here's another patient who's a 4-year-old whom I had operated at 11 months of age for lensectomy and vitrectomy for 4B ROP, and now he's one-eyed and he comes back with a sudden, inability to play for the last 1 week, and he's not speaking. And post-operatively, after the same technique which we did for 3 quadrants, you can see the retina is well attached, a good buccal indent can be seen, and that area of fold has now fallen back, as you can see. I have not shown my stage 5 ROP surgery, but what I'm showing is what joy we get. After 5 years, this boy comes and sticks out his tongue at you and says, "Doctor, are you going to do this again for the next patients?" And you say, "Yes, surely so."
Such great presentation, Dr. Subhara Jalali. Loved it, loved all your cases and the imaging, everything was so perfect. And I love the way you do your square buckle. It's very accurate. Everything's so well seated there. Congratulations for that. And I would like very much to have comments from the panel, and to start with Dr. Lam. Are you ready to comment Dr. Jadali's cases?
Sure. I think those are amazing surgery. It's never easy to be a pediatric VR surgeon. I think Dr. Halari has done an amazing presentation, making the procedure that she was showing look so so straightforward, so easy. But technically, is a very highly demanding surgery, and she has shown quite a few challenging steps of, for instance, the scleral implications in a young child with the very thin sclera. To undermine that and dissecting them is no easy task. And her surgical skill is amazing. Cutting close to the fold with the cutter, taking away the band that is over the retinal surface, is a heart-stopping maneuver. So credit to her beautiful surgical ability. And I just wonder, are you still doing those surgical implications, or are you have you modified those approach for those challenging cases that you were showing?
Yeah, so first I have to tell that my secret that I trained initially in 1995 or 94 on implants scleral buckles. That
Right.
was what we used to do with diathermy and all. So I have been very well doing dissections of sclera at that time when there was no vitrectomy. At that time there was no vitrectomy. We had only implants, scleral implant buckles. But see, this dissection of the sclera is not a big issue. We do it all the time for our bands and for our scleral patch grafts. So I think retina surgeons are quite well versed with making scleral flaps. So yes, in a child it's little more challenging, but actually when you hydrate that sclera, even in a child, as you saw, the flaps are quite good. If you are in a proper plane and you have good magnification and a new knife. But you have to be careful when it's a new knife. I have, the first time I did, actually, I did not make much of flaps because that was the technique which was shown in Japan in more recent years. But now I do make flaps because that really helps me to imbricate. The only other thing I do is in some cases where there's not too much fluid and I'm not going to drain, I do repeated paracensis. And then post-operative, within 6 to 8 hours, I open the bandage and I put them on Xalatan, some anti-glaucoma medication to take care of the pressure. All this happened during the lockdown because that time I had time to think. Normally, I operate 14 to 15 babies every OT, and there's not much time to think and innovate. But during lockdown, I could do it. I have done now 25 to 26 cases. Almost everybody is attached, and it's amazing. Someday I will show many more cases in publication. Patients where I would have not even thought of operating, those who come back with their Gardi. So this is a really good technique, especially when you can't see the break, or it's really good technique, and everybody can do. It's like a buckle. The only additional step you're doing is the imbrication.
So you're using this technique to replace the buckle, essentially. You're creating an indent in the cortion that you are concerned. And so why would you what's the advantage to use the scroll imbrication versus putting an explant?
So the advantage is that you cannot do screw buckles where there is too much of traction right around the break, because your buckle will not support it. So here what we are doing is we are not only supporting the break, but we are shortening the globe, and we are putting the buckle sort of behind all those breaks and all those pathologies. If you saw that photograph, that the buckle is going right behind those pathologies. So everything falls on the buckle, and there's nothing more causing traction. And there's exudation also. So if you do laser or cryo, it will worsen the traction in most cases. And many of these patients, you can't even make out where's the break. Like that small baby I showed you, 4-year-old, it is an aphakic eye, and the whole vessels are so small, I can't even make out where's the break. So it's sort of a blind procedure, but the break is somewhere. And the Linkoff's rule you can use to know where is the likely break, and you put the imbrication. It really makes the buckle go high. And
do you do cryo or laser in those cortions that you suspect or you see a potential break?
Yeah,
you do that before your implications, because you have to time your procedure. Like you do your cryo before you do your scriptal implications.
Yes, but a couple of cases I have done later also when the retina attached, then I could see the break more better, so I can do it under the buckle also before I close the case. So it depends. Sometimes I do laser post-operative also after 2 weeks when the fluid has gone. If I'm not very sure that everything is covered, then I might add some laser when the retina attaches. So all possibilities are there.
Thank you. Those are beautiful surgery, not done by anybody but you. I think you just make it very very elegant and very beautiful to watch. Thank you very much for sharing them.
Yeah, of course, and good. And there is one special person here, Dr. Vaibhav Sethi, that he indicated you as a keynote speaker, and we are so happy about everything we saw. Please, Vaibhav, make your comments on Subhadha's cases.
Ma'am has taught us so much that that's why I recommended ma'am to be the keynote speaker, because we're still learning from every presentation of hers. Even today, we learned so much, the imbrication. And ma'am, according to you, somebody wants to start pediatric retina surgery, what should be the surgeries one should take up doing? And what should be the stepwise approach for a person to shift onto pediatric surgery?
Yeah, so what I do with my trainees is that they should assist all the cases that I do, and pre-operatively, before the surgery starts, like under anesthesia, examine everything and make the drawing and write down your findings, and then see what the faculty is drawing. So the drawing of these patients, the more you do, the more you will get better. I think nowadays people don't do drawings, but these cases, please do the drawings under anesthesia, because these are children. And now we have the optos, so you can take pictures also of little older children and then study them in more detail. The most important, as I showed you, was the foveal attachment and the folds. Now you should start usually with those patients who are not one-eyed. Many patients are one-eyed, so obviously those, and start with the bad cases so that you are not causing that much damage. And then slowly you progress. I mean, if I can do, I'm not the good surgeon. If I can do, anybody can do. Anybody can do. Anybody who's doing adult retina surgeries can do. It's only a question of focus. So I have not done a macular hole or a diabetic vitrectomy for last 10, 15 years. I had to give up that. But now I do 15, 20 babies. It's just like assembly line. You can just do it. There's no difficulty at all once you shift your focus. One thing I wanted to highlight is there was a baby in this video who's 2 days old. So we are delivering the siblings of FEVR children. If the older sibling was blind, we are delivering them at 35 weeks. And we see them within 24 hours of birth. And we have a series of cases now. We treat them with laser within 24 hours. They all present. 60% of them have very bad FEVR. This patient was 2 days old. And then we go ahead and do vitrectomy if they have traction, and all of them do very well. If you wait, then they will develop all these folds. So these folds develop because we've not screened them on time and treated them on time. That is an important message I wanted to give.
I want to add, I think to do a good VL training, you have to spend time with Dr. Jalali. And you also need to have a big heart and a loving personality. If you don't have those, forget it.
You are absolutely right, sir. We were very privileged to be trained by high-end bio. We were very privileged and blessed to be trained by Dr. Subhadra. I still remember Madam Soar goes on very late in the night, and even at 10 or 10:30 in the evening, 10:30 p.m. Madam has literally held our hands and taught us surgery. So what you all, Ingrid, you said is absolutely right. Madam is a divine soul who has made pediatric retina look easy, but it's definitely not so easy. Ma'am, I just wanted to ask, people are very averse to screening ROP babies. Examination only will make you to understand pathology better. That is where you can easily go on to start operating surgeries. What are your tips, and how do you what do you suggest for younger people in ophthalmology regarding your ROP and ROP screening? Because that is what you have taught us so much.
So I think those who start screening babies, they just don't want to look at adults, because adults will keep on complaining. But the baby, he's under your control. You can move him anyway, and you can repress. And if they're crying, just enjoy that music. It's music to your ears. If the baby doesn't cry, then my heart stops. If baby's crying, it's good. That means baby's alive and healthy and good. So I think it's just a matter of accepting that there are babies and you can see their retina. So once you accept that, I mean, seeing a retina of a baby, it's not difficult at all. You wrap them up, you give them little sucrose, and you just enjoy their cry music. And they're under your control. You can go all the way around. Just make sure the mom and pop are not there. They are in some remote area watching some video or some television. So everybody can screen, and the important thing is that you see many of these problems which you see, the advanced disease, like the Coates disease or the advanced FEVR that I showed with folds, or even the PHPV, had you seen them at birth, the surgery would have been so much easier, and the whole treatment would have been so good, and the outcome, just like ROP, you treat it before the disease goes into a vitreopathy or folds, you get excellent outcomes, and your surgery is also just 20 minutes vitrectomy surgery. It's not big surgery. The more you delay, the more late you see them, then all sorts of complications happen, and you can land into phthisis and bad eyes. So I think the key is to start screening them earlier.
Ma'am, just to in a follow-up question to the scleral imbrication. So which are the cases which use which is a top like first line as a scleral imbrication? Because we have other techniques also which have been well proven beyond doubt about why don't you use a 240 or a 40 band? Why you want to use scleral imbrication? What is the extra advantage you are getting with scleral?
So see, with 240 and all, you are just supporting the aura. You are not supporting the break, which is hidden somewhere in that exudation and traction. So the cases that I want to use, these are the ones when you look at it, you say like, oh my God, why did it have to come to me? Why didn't it go to Natarajan? You know, why did this patient come to me? Why didn't it go to Lingam Gopalines? And I mean, I don't want to look at this case because I know I have to do vitrectomy. It will go into oil. It will go into multiple breaks. There will be some bleeding. I mean, there'll be so much happening there and I'll have to remove the lens. So these are the cases where I have started doing imbrication, and it's really a good procedure, especially those who come with fresh detachments and not much of PBR, whether it's, you know, so many cases. And the good thing is that even if you fail this procedure, there is no PBR worsening of the eye. There's nothing happening. You can always go ahead and do your second surgery of vitrectomy. I mean, there's nothing stopping you from doing that after 2 to 3 weeks if your surgery didn't work.
Dr. Halali,
You know, so last now. Yeah, I'm sorry. Okay.
No, continue,
Go ahead.
please. No, beautiful surgeries. I just want to say that I love your surgeries, but I have one question about late rub. I'm doing pediatric retina for 13 years now, and as you know, these ocular globes are so flabby and spongy. And my question is, this is scleral imbrication is probably a challenging procedure to do in these types of late rub cases. So what do you think about those procedure in those patients?
Which patients?
Late rub patients, late 18 years old, 20 years old with
that is the eyes where it works the best. That is the eyes where it works the best. Someday, if I have time, I can show you more videos. I mean, this is what, because the first time I had to do, I asked Dr. Lingam Gopal. He has done few cases, he has not published. He didn't have a video, but he was the one who told me, but they don't put a buckle. He said that he just does the imbrication in 1 quadrant or 2 quadrants. But I was not very comfortable just imbricating because I wanted to have a good buckle also. Those are the cases, those adults who come with all sorts of tractions, and you have no idea where you're going to land in, and their vitreous is bad. They have retinoschisis in addition to the folds and in addition to very thin retina. So I have been doing vitrectomy for those eyes for 20 years, and I have been crying because my success rate was not more than 30% in those eyes. I would invariably create a lot of problems. But now with this technique, I feel very confident. In most of the, I told I have done 26 cases in last 2 years. So almost every month I'm doing 1 or 2, and every success makes me wonder like, oh wow, I wish I had known this 20 years ago. So please try it out. Please look at those cases. Please do this technique, and you will find that, you know, you are really doing something great for these patients. Single surgery success, no silicone oil removal, no cataract. It's not going to work in every patient, obviously. But, you know, if you understand the pathology, where the break is likely to be, from where the traction is coming, and you can, you know, buckle the break quite posterior and all the pathology goes anterior, it really works.
Wonderful, Subhadra. So I just wanted to tell you all seen how great surgeon she is. She's a great dancer, Hudson. And we both bring energy to all the retina meetings in India. Thanks to Subhadra. And one more, I have a partner, Kero Bilairi. One day, I think she's also had so happened, my fellow and a vitreoretinal surgeon doing pediatric retina. But Subhadra really, one thing is about passion, the way she works. And she's from Kashmir, which is a beautiful place of India, where you have the snow. And she's from there. And unfortunate that I couldn't take her in 91 because I was also struggling in Mumbai, and she went to Hyderabad. But anyhow, she's doing great work because I think that's what is the destiny, and good that she didn't come to me. She went to Tara Prasad Das. Good, Subhadra. Great. Keep it up.
Thank you, everyone. And I'm only an email away. I'm only a WhatsApp message away. Anytime, any issues, I'll be happy to discuss and learn from all of you. I have learned so many things from, you know, so many surgeons, from Wai Ching in his videos, and so many more people. So thank you, everyone. Together we can work and, you know, learn from each other. I think that's awesome.
Thanks, Dr. Subhadra. We have here a fellow of yours that is very grateful for being your fellow, is Dr. Sushman Jayana. She's saying that she's so pleased to have been trained by you, and if she wants to comment anything, Dr. Sushma Jayana, would you like to comment?
Hello.
On?
Sure. Thank you so much. Thank you so much for asking me to speak, because I have been with her almost like 1 year, along with her in her OT, staying with her till 10 o'clock, 11 o'clock. And I can vouch that she will do with the same justice 10 o'clock surgery in the night, the same energy she'll be doing it in the morning 9 o'clock. So she is just from another planet. That's all I can say. No human can match her energy. So we are all blessed.
Sushma is working in Bhutan, and she's seeing amazing cases there. I think she's the first retina surgeon working in Bhutan. So we are really looking forward to her work and tell us what is happening in Bhutan. We don't have much information of retina in Bhutan. So yeah, it's wonderful.
Thank you, ma'am. And the confidence all of us have, it's because of your training. That much we can tell.
Sushma, Dr. Natarajan here. Dr.
Yes.
Vivek Balakrishnan is an ophthalmologist and a minister for foreign affairs in Singapore. He was always asking me that I should do so. He's a pediatric ophthalmologist, but anyway, he's now a minister. But he wanted me to always help Bhutan, but I've never been. So in case you need anything, I'm ready to come and do volunteer service there.
Sure, Dr. Natarajan. I'll reach out to you. Yeah.
So we have trained one more surgeon. He's joined her now. He did his fellowship 2 years here. So both of them, hopefully in Bhutan, it's a small country, so hopefully they will be able to manage all the retina cases. The one other thing I wanted to tell, there was this case which I showed very briefly about post-Avastin. Suddenly a break has happened, and the next day after Avastin, child has come with Reg-RD. So someday I will show more cases of Reg-RD in pediatric tractional detachments, because general thought is that if you create a break in these eyes, it is gone. It is not gone. You can still salvage them. Just stop and do little vitrectomy. Just remove the vitreous around that break and close it, and it will be successful. You don't have to remove anything else. You don't have to do a complete vitrectomy, complete PVD. Just treat it like a small macular hole, and it goes. And then remove the oil within a week. You don't have to keep it for a long time. They'll get amblyopia and cataract and glaucoma if you keep it for longer.
Thank you very much. And that's the aim of this meeting, to discuss, nice cases and get experiences from people from around the world. And of course, we are learning every time with our experiences. People operate, people do surgeries in different ways. I saw here Sasamoto was with the hand raised for a while. You still want to comment anything, Sasamoto, Marcelo? Or everything is okay? If not, we should proceed now to Dr. André Jucá, who is presently at this moment in his operating room with some fellows. And Dr. André Jucá works in Fortaleza city, a large city here in Brazil, and he owns a service there, a retina service, an ophthalmology, general ophthalmology as well. And he had his training in Le Cansvan, Le Hôpital de Paris. We visited Paris last November, and we had the opportunity to see some of his friends back in Paris last year.
Thank you very much for your nice words, my friends. I just brought a case here that was a little unusual for us. There was a patient that had a surgery of a retinal detachment surgery. She was a very high myopic patient. She had had an implantation of an ICL lens, a fake lens, in the posterior chamber 15 days prior to the first retinal detachment. And she did a vitrectomy because the break was too posterior. But after the gas reabsorption, she developed an epiretinal membrane and some cataract. So we had here to remove the IOL, the ECL, the lens, the cataract, and the pucker. It was quite difficult to convince the patient because she just had the implantation. She spent a lot of money in this first surgery, and now she had to remove the lens that she paid so much money. This was a young patient, and she was she had accommodation and everything. But anyway, this is the cataract, as you can see. And here is the ICOL with this hole in the middle to avoid block. This is the epiretinal membrane. And the vision was bad, but mostly the retina was attached, although there was some traction in the periphery, as we will see. We are using trypan to try to stain the anterior capsule as well, the ICL, as you see. It's not difficult to remove, although it's this case is try to get a good refractive result, may be more challenging. Here we are just cutting this lens. You don't have to cut it completely, just cut it until the middle. It's enough. Then you can just, it's very soft. You can just turn it like a pizza, and it's going out. And then you just go ahead and do a regular vasectomy. It's you see that the anterior chamber is very deep because the patient is 20 diopters of myopia. It's a very big eye, and but there was no problem. Sometimes you may have some rupture or descent of the bag, but everything was okay. We just choose to put an alcon lens. We do not have a multifocal lens in this diopter, although we think that it's not a good idea to put anyway multifocal lens in these patients. Then we went to, this is, you see here the first break. You see that the retina is attached, and we're using trypan blue to try to see also a little bit of the internal limiting membrane here. We are removing the epiretinal membrane. You see it's quite thick. And you see there is a lot of vitreous schisis in these patients. And we are removing it. I think the vitreous probe is good. Forceps sometimes induce too much traction and you can have breaks. Anyway, you got to remove these vitreous attachments, and then we just did a little bit more of vitrectomy. And then we put a little bit more laser in the periphery because you see there is a little bit more of laser. Because sometimes you get micro holes. This was 15 days later. And this was 45 days later. You see the membrane is gone. You have really good. And the best was the refractive result. That is really quite nice. At least the patient do not have near vision, but it's good for long distance vision. Just this take a whole message. We use the Barrett-2 formula. The ICL lens do not interfere with the calculation. You can just forget about it and do the calculations anyway, it just works fine. And really, vitreous schisis is quite often, it's present in most of high myopic patients. And we have using triamcinolone to try to remove most of the vitreous. It's very useful. That's very useful using and to see vitreous schisis. Thank you all for your attention. This was our case that we just brought here. It was something that we do not see every day.
Great cases, great images as always, André. Would you like to comment Dr. Juca's cases, Dr. Lem?
Yes, I think operating on the high myope is always a challenge, especially the long axial length. Did you require any special instruments to reach to the back of the eye?
Yeah, we have, in this case, no. Sometimes we use a special forceps, but since we use the probe, we did not need it to remove the membrane that was associated with the vitreous cases. So the probe may be good to avoid inducing more holes in the periphery of these cases. But sometimes we do have a longer. But if you do not have a special forceps, there is 2 tips. You can remove the trochanter and go a little bit back. These 2 tips can help reaching the posterior pole in these very long eyes.
Yeah, I find that the high myope vitreous schisis over the macular area is hard to grasp with the forceps. So I often use the Tenno diamond dust membrane scraper to go over the macular area to remove the vitreous. And I highlighted with triamcinolone. I found that almost 99% of the time I was able to remove more than 1 layer of vitreous, and they often manifest as almost like onion skin layers. Like so, then I stained for the IOM, and because with the presence of residual vitreous schisis, it really prevents the staining of the IOM. And in your case, I didn't see you. You actually need to do that. You went right over and able to remove the IOM. And so do you routinely do kind of a scraping, or you just go with the forceps?
Yeah, this case was really a thick pucker, so it was easy to see that no need to stain. Although I tried to stain it, it did not stain very well with membrane blue anyway. But sometimes I do like that. I just put triamcinolone on to check it. But you see that membranes, after sometimes they grow thicker, and it's easier to remove and it's easier to see as well.
Yeah.
If you operate too soon, then it's going to be much harder. And I think you are right, Dano. It's a wonderful tool for these cases.
Thank you. There was a beautiful surgery. Thank you for sharing them.
Thank you very much.
I loved your cases, André. And I was listening to Dr. Lem commenting on maybe using the scraper or the Tenno, I guess. Yeah, you said the Tenno. I like using, I have this kind of shaving technique. I'm going to share with you my case later. And because sometimes the ILM is so taut and so hard to peel off, especially on those cases of macular pucker, such as the one that I'm going to present. And some cases with a very adherent and chronic epiretinal membranes. And I like, double peeling, but I like to use the brilliant blue twice to stain after the first use of the brilliant blue to remove the epiretinal tissues, and then I stain it again, now this time without nerve fluid exchange. And in this way, it's possible to see better the ILM, but still, if the ILM is so taut and so adherent, this shaving technique that I like using with the forceps, because the forceps, it's sometimes it could be pointy, but sometimes it's round. So you shave very carefully. I was listening to Dr. Athanasius in the last Retinawesome 13, he was mentioning that he likes using the forceps for just passing actually the backflush cannula with a silicone tip on the macular area on the internal limiting membrane to kind of lose it, make it loose and more prone for peel. And so great comments from Dr. Lam and removing these tissues that maybe they do not stain well due to astrocyte proliferations and other adherences there. But great case, and especially in high myopic patients, it's very tough to do and carry on these procedures. And anybody else would like to comment on Juka's case?
Hi, Hudson, how are you? Thank you.
Hi,
Hi, Dr. Juka, excellent surgery. I loved the cataract technique, fantastic capsulorhexis. Good choice of the lens. A three-piece lens is a very nice lens for the high myopic patients because the bag is too big and too fragile. So actually, it keeps it well with a three-piece lens. My question is, usually I use a contact lens to do the ERM peel, and I didn't see you use one. So do you do it with a biome or the ReSight without using a contact lens? Because I prefer using the contact lens for better magnification and knowing exactly where I go.
We did a study. Sorry, Dr. Juka. I thought the question was for me, but because of my comment, but I think it's for you. But I will add just before you comment that I don't like biome, for example, because I prefer contact systems, and I think the image is pretty clear. We do not get much interference from air or media. I think it's better. Everything I do is with a contact lens. Okay, Andre, sorry.
Yeah, Emmanuel, hi, how are you doing, my friend?
Thank you, thank you.
Yeah, you're right. I did use the contact lens for the posterior pole to remove the pucker, but in the periphery, it's not possible to reach the far periphery with flat contact lens. Of course, you have prismatic ones that it's attainable. But for the periphery, mostly you use biome, you're using Ingenuity. So Ingenuity, good stereopsy. But still, I think you're right. The stereopsy with contact lens is superior. And for macular surgery, I still, although some colleagues do use biome for them, I still prefer to use contact. I think they do have superior stereopsies.
Thank you. Great surgery. Thank you for sharing. Thank you.
Dr. Juka, very nice case presentation. Would you also maybe planning using trypan blue instead of brilliant blue in such a case to stain the ERM? Would you think that would be also a good choice?
Yeah, but we just did that. That's the membrane blue that we call the trypan blue because it stains better than the membrane. The brilliant blue is done specifically to color there is so many fellows here to color the IML. So you are right, for membranes, epiretinal membranes, the brilliant blue is not appropriate. I think trypan blue it's better. Of course, that if the membrane is thicker like that one, and then you do not need to stain to see well.
Okay. All right then, and thanks, Andre, again for great cases that you always present, and we love to see, especially these wide-angle, beautiful images. These, it makes easier for us to understand the whole picture of the thing. Thanks, Vaibhav, for your comments, and I would like to call Emmanuel again for presenting his always good cases in Retinawesome 14. Thank you, Emmanuel. It's a bit of time we do not speak, but you are always welcome. And I hope everything is okay with you and with Europe in general, even though we see these war things happening everywhere around Europe, but hopefully this is gonna end. And I think you are already co-host, and you are free to say some words and share your screen, if you will.
Thank you, Hudson. A great honor and pleasure to be here with you. Thank you for the invitation. I love participating on those fantastic meetings and hearing Dr. Professor Lamb's comments. Now, Greece is fine. I mean, we are now in end of March, and we had a very bad winter with 0 degrees and -1 or something. But the last 3 days, the weather is beautiful, and spring and summertime is coming over. So I'm looking forward, seeing you for summer in the Greek islands. Now, with regards to the war, yeah, unfortunately, those are things that should not happen, and I think it should end as soon as possible. I wish all the best to the Ukrainian people, and see how it goes. Let me share my screen. Right, so now you can see the full thing, right? Okay.
Yes.
Thank you. Great. This is a 40 years old gentleman who is presenting with reduced vision in his left eye for the last 2 days. His past medical history is negative, and concerning the ophthalmic history, he has high myopia of -8 sphere. Now, the visual acuity is 20/30 on his right eye, and hand movements on the left eye. Anterior segments are normal, and he's 40, so he's phakic. And on fundus examination, the right eye, the retina is attached, and the fundus is myopic. And now, you discussed about drawing. I always draw, so I love drawing. So he is presenting with a macula of a giant retinal tear, starting from 2 o'clock and coming down to 5 o'clock. And this is the B-scan ultrasound image of his detachment. This is the video. It's a vitreous. There is a vitreous hemorrhage as well. So I start with the vitrectomy, cleaning the vitreous hemorrhage. Then I remove with the cutter the anterior part of the break, so I can minimize any kind of PVR-induced post-operative issues, and relieve all the tractions anterior very thoroughly. Then I gently manipulate with the 2 instruments the tissue, so I can unfold the folded retina, which is almost fold back to the macula, and then I very gently mark the posterior edge of the giant tear with endodiathermy, so I will be able to see it later on, as well as the 2 horns of the giant retinal tear. And then again, with scleral depression, I try to, you will see in a minute, under scleral depression, to remove any residual vitreous anteriorly. So again, to reduce any post-operative PVR and remove the redundant retinal tissue that is not going to be of any use. And then the reason I'm showing this case is that I don't like PFO. So I try to avoid PFO, and I will reattach this giant retinal tear by using air fluid exchange. And the way I do this, I'm sure you all are aware of it, is just to stay as much as possible, as much anterior as possible, and be very patient to remove the fluid under the retina. So the giant hair is completely unfolded, and it is so that you cannot be successful on this with the first instance. You need to insist and be patient. As you can see, is not unfolding. However, it's okay. It will unfold. The thing is, you need to be patient and keep draining the fluid. And as you can see now, I have slippage. So you can see here that the retina is folded. And again, the thing that it will happen is you go in, you very gently touch the end of the edge of the retina, and just you pull it to its original place. And as time goes by, and as the fluid is removed, then gradually the retina will come to its place, and the slippage will be avoided. So now that the retina is back to its place, as I start lasering first the posterior part of the break, and then I will continue to the anterior part of the break. And then, as always, I do cryo, as you can see here, to the horns of the break. So I'm sure that it is cryoed, and I will not have any recurrence of the retina detachment. And finally, again, persevering and removing the fluid. This is almost the end of, actually, this is the first horn, and this is the second, the superior horn of the giant retinal tear that I do cryo again. I do cryo. And then, as I was saying, just, persevering and be patient, and removing it again at the end of the case as much as fluid from the anterior part of the break. I do C3F8 air C3F8 16% exchange, and let me stop sharing. Oops, sorry. I just want to go to the next slide now.
Cool images, Emmanuel. Which system you're using to do the surgery?
This is the Recite. This is the Recite, and the 23 gauge Constellation. So the viewing system is the Recite. Just give me a minute so I can go back to my
And what strategy you used to avoid PF?
That's exactly, thank you. So this is my next slide that unfortunately I won't be able to show. So immediately post-operatively, I put the patient on, it was the left eye, on a left side posture for 2 hours. And as you know, the thinking behind it is the left eye. So I want to drain as much fluid temporarily as possible. And then after the 2 hours, I place the patient face down strictly. And if I will be able, I have now five months follow-up, which is I cannot get out of from the video. I don't know why.
Not a problem. That was cool. And I was asking you, how would you avoid the PFO from getting under the retina? And then if it goes under the retina, you remove it and then you put it back again?
Right. This is what I want to avoid. That's why I'm not using it. So, this is a macula of retina detachment. If it goes under, I mean, when we start fixing PFO under the macula in a 40 years old man with a good, good prognosis for visual acuity. Now, 5 months, the visual acuity is 20/60, and the OCT macula is absolutely fine. So that's why I try to avoid it. I'm not very, in my 10 years career, I'm not very experienced with using PFO. I try to avoid. So, and if I use it, what I try to do is relieve as much vitreous traction as possible. So I reduce any chance of the PFO going under the retina. And then very carefully, by staying over the optic disc, I inject slowly and very carefully, just to see the gradual insertion of the PFO and that squeezing the fluid out. And once I reach the edge of the break, then I stop and I carefully see how the retina is behaving, just to make sure that I'm not going to have any PFO coming under the retina, because it's going to be a nightmare. So yeah, that's how I do it.
All right, and I would like to welcome to Retinawesome 14 also Dr. Anita Agrawal. It's an honor to have you here, and if you want to comment the cases, and you are free to do so, because you inspired us, and I'm sure that our professors here, like Dr. Lam and Dr. Subhadra and all the others, Dr. Natarajan, they welcome you too. Thanks, Anita, for being present in the Retinawesome 14.
So I don't know if you can see, this is the 5 months post-op OCT. You can see it or not? You can, yeah. So it's quite all right, I think.
Cool result. You know, the macula is flat with the good shape of the fovea. And would like Dr. Subhadra would like to comment on Emmanuel's case.
Yeah, Emmanuel, that was so nice, because I also belong to the old school. I have gone from air to lots of PFO and now back to air. And the reason for that is twofold. One, of course, it's very troublesome that you're finishing the surgery and one small bubble goes behind, and it's like that mosquito who just keeps on troubling you, that fly who just keeps on coming in. It's such a pain to, remove that small bubble, and you don't want to leave it behind. But more important for me is that what I have seen for many fellows also, I see they put the PFO thinking that, the retina flattens. And of course it flattens if you put enough PFO. But there's a lot of vitreous left unremoved, and it then comes back under the oil to haunt you. And that is how the recurrent PBR happens. And when you go back and do those surgeries, you see that, oh my God, so much more vitreous was left behind, especially in the periphery or in the area of the lattice and the base. So really, I mean, the air tells you the truth. Because if the retina doesn't go back, there's some slippage, you have to have patience and, go soft. But if the retina doesn't go back, that means there is vitreous is there. That means your surgery is not good enough. You still need to do more, whether using Tramslone or using a bimanual or whatever. You need to get that vitreous out. So I think I reserve PF only for select cases. Very often for recurrent cases rather than primary cases. So this was awesome. You really showed a good technique. I think, as you said, it requires patience, but otherwise it does well. The only thing is sometimes, especially in very high myopes, there may be folds posteriorly, left behind, and that has to be flattened by a strict face down. Otherwise, they will keep on complaining of metamorphopsia. So, the road roller technique, as you said, you first put in one position to tamponade the break and remove the fluid, and then you put them face down so that the fluid doesn't seep posteriorly, and then they are, they do well. Otherwise, you can have folds in the foveal area and they will have very bad metamorphopsia later.
Thanks for great comments. And would like to call Dr. Marcelo Murilo Sasamoto. Marcelo is the president of the Bolivian Vitreoretinal Society, and he's our neighbor around here in Brazil, Bolivia. Thanks, Sasamoto, for being with us and sharing your great cases.
Well, my case is about an 18-year-old male, a high myop also. And what I like to comment is about the vitrectomy that we performed. It was a retinal detachment. We used this 3D microscope from Hackstride and the Oertli OS4 platform. So it was a really interesting case, pseudophakic patient that we performed this vitrectomy. It was kind of hazy because of the fibrosis of the posterior capsule. You can see the inferior retinal detachment. I like to use triamcinolone in these cases to recognize the vitreous. And then we are aspirating this subretinal fluid. And it is a conventional procedure. But what I like to mention is what we are going to do in the next step. We are going to attach the retina, put some laser to recognize the detachment and the holes that are in the inferior part, air fluid exchange. And then when we recognize everything, we remove the trocars and put our scleral buckle. So I believe it's a very wisely formed to put the scleral buckle in this patient. All the retina is attached. You can be more exactly with the indentation that you want to perform in this type of eyes. And then once we do that, we put again the trocars to see that everything is correct in the posterior pole. The one complication that we had was the low visibility that at the beginning we had. Then we put the trocars and see everything, complete our laser and the laser treatment, and put some silicone oil because it was an inferior retinal detachment. There are a lot of procedures and techniques in these patients. I like to do, if I can, this scleral buckle procedure. I think it's better for be more exactly in the indentation, and it's a small case, but I think it's useful in this type of patient. I love wines. I have a small wine cellar, so when you want to go to La Paz, Bolivia, you're very welcome, and we're going to share some very good wines from Bolivia. Thank you.
Thank you, Marcelo, and congratulations for your new baby that came just a few months ago. Congratulations again. And we are so happy to see you displaying those pictures in Instagram. You are awesome. You know, I love to see your family. And,
thank you, my friend. Thank you.
If you wanna comment, anybody wants to comment on?
Wonderful, Marcelo. I think nice case and very clean, attached retina, and you've done buckle and oil. But I think the only thing is to just make sure before you inject oil, make sure all the vitreous is removed so that you don't have a recurrent fever. And I think Shubhadra also has commented that PFCL, sometimes when you use, you may think that the retina is attached, but I think when you remove the PFCL, you know. So best is to reattach retina without PFCL, but in case you use, make sure all vitreous is removed.
Excellent.
So you can probably stain with a steroid and make sure there's no vitreous left at all. But good case.
Yes, yes. Thank you, Natarajan.
Yes.
We had a bit of some issues in the sound at the beginning because we were presenting here. It's theater, and we have this YouTube was going live, and then we shut off the YouTube, and everything goes fine. But then we're gonna be presenting in the YouTube this session as a premiere in YouTube later on. And I'm very pleased to call again here to this stage Dr. Francine Veiga from, it's better for you to introduce yourself, Francine, because you've got such a very good CV, you know, biography, that your cases are amazing. And I would like to welcome you again to this session of Retinawesome 14. Are you around, Francine?
I think she was there, but again, she's logged out, I think. Maybe, oh, she's come back. No.
If not yet, she might have been disconnected for a while, but she was in another meeting, but she's back and forth, but she's gonna show up here. Yeah, she's there in the Retina Grant Rounds, and
Yeah, that's right.
we have these sessions here, these study sessions weekly. This is very interesting. This is called the Retina Grant Rounds, and everybody's welcome to participate. We have many services here in Brazil involved in the Retina Grant Rounds. Every Thursday, it's 6:30 a.m. Brazilian time, which is different time from all you, but we are planning to have this translation to English simultaneous. So it's gonna get a while, but the system is gonna get converted to that as well. And I'll call Francine, but if she is not in the room now, I will present my case, and then I will leave Francine's case, the last one, because I'm pretty sure it's a pretty cool one. And so I will share my screen. Can you see the screen? Is that there? Let me enlarge the. This is a vitreoretinal case, and has much to see, not much with pediatrics, but with what we discussed in previous cases. So let me go on.
This is inverted vitrectomy. Double stain with brilliant blue for tot macular pucker. This is the preoperative OCT showing a very adherent and tot macular pucker with a large traction. We start the vitrectomy. The patient is a phakic with a pretty clear lens. Using a wide-angle vitrectomy contact lens, we perform core and peripheral vitrectomy. At this point, here, we are detaching the hyaloid so as to free up the macula from vitreous adhesions. Peripheral vitrectomy should be performed extra carefully because the patient is phakic. You can only do a safe vitrectomy if you rotate the eye altogether with the action of the vitrectomy with the cutter and illuminating pipe towards the very periphery. With a macular lens, you have a great view from the fundus for an AFX, air fluid exchange. A complete AFX is performed so that enough brilliant blue will be injected towards the MAC surface for a good staining. Brilliant blue is injected. carefully on the macular surface. There is no need to pass the arcades for the staining. The adherent and taut epiretinal tissue is then removed after an edge is grabbed and lifted carefully from temporal to nasal. The pucker is peeled off as in an unblocked manner, freeing up the macula thoroughly. You may notice vascular traction and tortuosity at vessel sites. Another brilliant blue staining is carried out, but now without an effluid exchange. It is possible to observe that another good staining is achieved, but the remains of the epiretinal tissues as well as astrocyte proliferations will be removed with a shaving technique, again cleaning all MAC surface of any adherent tissues that could have not been removed in the first attempt of the peel after the first brilliant blue staining. Shaving the macular surface is not an easy task, as appropriate and controlled force is applied as a scrape-away-like movement, very gentle and aiming to remove remnants of attached tissues both from vitreous and together with the ILM basal membrane of Miller cells. Endolaser is another step so that the peripheral retina will be protected, mainly at the sclerotomy sites. The lens remains clear at all times, and you may observe here the good red reflex and clear lens towards the postoperative periods, as well as the good retina looking and now without the macular pucker. These are the postoperative OCTs and the retinal pictures and FA showing a pretty good macula, of course still with cysts due to chronic traction and edema, the traction now being totally relieved and a better chance for treating the edema with anti-angiogenics. Thank you very much for your attention. We appreciate it.
Yeah, this was a tough case. We get this chronic, very chronic, macular puckers, and we do beautiful surgery and things, and remove the membranes and carefully. But sometimes, and oftentimes, because the traction is so chronic, you get these cysts there, and of course, you wouldn't treat without peeling off these membranes. And now, if you have cysts from the chronic action of the traction, and then I will proceed to doing the injections in order to get this view better. And I want to ask you guys, what do you think? I was thinking, just concerned about, could that be a different technique for us to help the shape in the postoperative periods, like doing the surgery, injecting PFO? Would that be of any help to use the PFO to weigh on the retina to relieve some cysts? But they are chronic, so it's a tough thing to do, of course. And then you have to keep treating the patient. And then I decided to have the patient be injected sometimes for relieving. And another discussion is what to inject. Idea, you know, anti-angiogenics or Ozurdex for better and long-standing actions. And I would like to discuss this with you. What do you think, Juca?
You are muted, Dr. Juca. Please unmute yourself.
Thank you. This happens often. Sometimes it's just edema and sometimes it's retina degeneration. These sparkers, they are present for a long time, and this kind of degeneration do not respond to corticoid. Anyway, I also almost always try some corticoid. Ozurdex is good in vitrectomy eyes. So I try Ozurdex, but some component may be due to retinal degeneration and may not respond to corticoid. I don't think anti-VEGF will work. Nice case. Congratulations for that. It's really nice case.
Yeah, thanks. Would like to comment, Dr. Subhadra?
Yeah, excellent case. So just 2 points, because there are some residents also here, that when you have a young patient with such a thick membrane, always we need to check the periphery, because there are sometimes angiomas or a PBR which are, you know, causing this problem. Now, if the edema is there post-op, how long should one wait? Because some of the edema could be surgical induced also. So I usually wait 2 months, and I sometimes put them on dorzolamide for that time, especially if I'm thinking of degeneration, because the macular edema of degeneration will respond, although slowly, to topical dorzolamide. So if I am not injecting immediately and I want to wait for some time, then I usually give dorzolamide for a couple of months. And if it doesn't respond, actually it does respond in some cases. If it doesn't, then, you know, I go ahead and inject steroid. But maybe Anita is here. She could possibly tell us some more about macular edema from, you know, point of view of medical retina, how we should manage these macular edemas.
Yeah, I think you are right, and André is right as well. And corticoid would last longer, and we are having such good results with corticoid, and it lasts longer, and then you can repeat, and of course you have to control the pressure. But this, if the patient is not a glaucoma patient, it usually works very well. And I've got great responses with chronic cysts with corticoids. And they, after you remove the tractions, and of course, they're gonna get better over time. And have you seen such chronic cases like that? You have the same experience, Natarajan?
Yeah, so I think one is no role of PFCL. I think you mentioned about the peripheral retina, but I don't do a laser. Make sure that I do a depression in case you are suspecting traction on the near the ports. But I think the main thing will be, I have some cases I've done with chronic cases, injected Ozurdex on the table, making sure the optic disc is okay, and then maybe repeat the Ozurdex 3 months later, because it may take long time, and also put them on topical Nevenac, making sure there is no corneal complication. But I think your post-operative result is excellent. The serial OCT shows it's great. But I think the cyst will go with the steroids.
Yeah, I agree. I was just concerned and thinking about using those tamponades because the mechanical action they could provide. For example, this case is it wouldn't be good in my thinking to leave the patient with silicone oil, because you know this surface tension from silicone oil is not that high, and gas is a lot higher, but there is a point of the lens, and leaving the gas there with positioning, even though you put non-expansible gas, it could well hit and touch the lens, and then you get a cataract very early. So I don't actually think this would be better than later injecting, like the corticoids. I think
Yeah,
would work better.
There is no role of any tamponade here. It's not, you have released the traction, that's what you have done. So that's why any retinal membrane surgery should not be taken light. And I think you have to discuss the pros and cons which you have mentioned to the patient. And that's why case selection, these sort of patients, definitely you need to do surgery because the vision will not be good with thick and adherent membrane. So I think no tamponade, but I think good surgery, make sure you do induced PVD, and also you can do double staining, as you rightly said. And Dr. Peter Kroll in Marburg called it a chromovitrectomy. We're using the steroid for vitreous for staining, and then using the brilliant blue or any of the stain to stain the thing. And also make sure one more, I think clue is sometimes after doing the steroid, and then when you use the brilliant blue after the membrane removal, the ILM may not get stained. That means still some remnant is there. You may have to dissect the second layer of membrane, and then make sure that there's no traction on the macula.
All right. Anita would like to comment. And you've got such nice books with, the gas, Ryan. And I always have your pictures as a profile and a sample for teaching the residents and fellows here. They love it. And to comment on the case?
Thank you so much. I guess I was on my phone and I had to figure out how I was going to get myself on the video and the mute. I think everybody's already commented on chronic or thick epiretinal membranes, multi-layered epiretinal membranes. Personally, most when I do a regular membrane peel, I don't remove ILM. I think ILM comes out with some of these membranes anyway. The only times I remove ILM is if I have multi-layered ERMs. And I think the key thing is, at least to me, I don't think that the ERM stain. So if I see an ERM and I suspect either there's a macular hole or the multi-layered ERM or anything, I first peel the ERM without any stain. I just use a bent 25 gauge needle and pick on the ERM. And I feel like after a few minutes of looking at the macula, your eye adapts to the macula and you start seeing more and more things. And a bent MVR blade or a bent 25 gauge needle is good because you can pick on it, and if you can see the edge come up, even if it's so transparent. And once you see that, I peel all those things off. And the times I stay in ILM is only if I think that, it's multi-layered ERM that's, I may have left strands around here or little pieces, and that's when I stain. Generally, I don't use stain for ERM peels except in those special places. And I think restaining a second time is good, because first time the ERMs really don't take the stain up. And once you've taken the ERM out, then the ILM will pick up stain, or you can see edges of ILM already torn off in some places. And it's very easy to find them and then peel them off. I think if we have intraoperative OCT, that's probably the best way to know that everything's been taken out. But short of that, I think using stain and sometimes repeat stain. And I don't leave the stain for too long. I leave it for less than 20 seconds, 25 seconds maximum, because you can always go put more. I don't like to put too much stain in with all the toxicities that we had in the early stages of staining. So, and most recently we started using brilliant blue. We couldn't get brilliant blue till recently. And I've used them a few times, and I think they both do well, ICG and brilliant blue. And as far as those chronic CMEs and chronic ERMs with macular thickening, steroids I think is a big plus. Of course, if they have glaucoma or they're high myopes with borderline discs, then you have to worry about them. I think even intravitreal triosens, just to kind of blast and get the edema down first, is good. And as Subhadra mentioned, I use Diamox or dorzolamide in those which have an element of inherited or degenerative diseases, but most otherwise, I think steroids. And I use regularly for all my epiretinal membranes, diabetics. I use topical predforte for a long time, maybe 6 weeks, 8 weeks. I don't take them off. Steroids, I think my colleagues use them for 3 weeks and they just take them off. And all the ERMs, they are on predforte for a longer time. I think steroids really help, especially ischemic diabetic eyes. Steroids help a lot. They kind of calm all the ischemic inflammation that you get. And I use steroids unless there's glaucoma. I use a lot of steroids.
Yeah, thanks. And I agree with you. I like to double stain because after the first staining, especially for those cases and very taut and adherent macro pucker cases, after you remove the first membranes and then for the first staining, I do air fluid exchange. I also leave the brilliant blue for less than a minute, not to be toxic. Anyways, I did not find it toxic, but I just leave it for maybe, as you said, 20, 30, 40 seconds, not more. And then after doing the first work, the first peel, I stain the second time straight on the macula, but now I don't do air fluid exchange. And if you see that particular case, it stains, it really stains because you don't have any barrier anymore, like the epiretinal membrane or epiretinal tissues, and then you get to see the ILM. But unfortunately, those cases, the ILM is so taut and so difficult to peel off that you got to be very careful, actually extra careful.
Anyone can answer this question, sir, for the panel. I mean, in which cases would you actually observe closely and not do a ERM surgery with cysts?
I myself go, you know, this patient was operated like a month ago, less than a month ago. Actually, this 21 postoperative period, I saw him last Thursday. So by next week, I'll start injecting him. So I don't want to wait too long because otherwise the cysts, even though the cysts are chronic, they might get worse, I think, because, you know, the inflammatory component of the surgery itself. So I prefer not to wait much and to proceed with the injection. I was just concerned about deciding which one I was going to use, and I'm deciding here with you that corticoid, Ursodex, that we have here, it's a better approach. Dr. Lam, would you like to comment on Dr. Agrawal's comments, you know, on that specific case?
Sure. I just want to follow with what Dr. Sati has asked. If you wonder whether you should do the ERM peel, you can always do an FFA. And if you see a pedaloid leakage rather than attractional changes, then that case will benefit from steroid first and see how much reductions of the intraretinal cystic changes improved before you went on to do your ERM surgery, because the ERM can cause cystic changes, but those cystic changes are mechanical and they should not leak. You might get some leakage from the direct tractions on the vasculature, but you shouldn't get pedaloid changes from mechanical alone. So that could help.
Yeah, and maybe also if it's like a post-uveitis ERM and still there's some inflammation, you may want to inject the Ozurdex before you do surgery. And also sometimes there are decent cysts, but the vision is good. You know, it's not always that if there's a edema with ERM, the vision is bad. If the vision is good and you discuss with the patient, then you may want to defer surgery, especially in young people. Ultimately, they'll get cataract or other problems. So sometimes they may want to defer surgery if the vision is good, and that may be the place for non-surgical approaches. You know, with the caveat, of course, and you know, the thin ERMs, they're not causing much traction and there's more edema than traction. You would definitely want to. So one need not worry that the steroid will cause more worsening of the membrane. But rarely, as I showed in my video, when you inject, they can suddenly develop a tractional tear. And, you know, next day they can come back with a reg RD. So, you know, you have to be prepared.
All right, thank you. Thank you for discussing that with me. We learned together. And I don't know whether Francini is around. She was in another meeting, and I'm not sure if she made it to the meeting. She came back and forth, and she's probably giving a lecture now, but I'm not sure because she's not answering. But anyway.
She was there in between. She was there in between, but now again, she's not here.
Yeah. But if she does not show up, that is not a problem. We could save her case for Retinawesome 16, because Retinawesome 15, we are going to be in Saudi Arabia, and it's going to be the first, actually the second, because last year we had this Retinawesome Paris, which does not carry a number, in Paris last November. And now the second presential Retinawesome meeting will be in Saudi Arabia, in Riyadh, next May, by the end of May. And Dr. Lam, Dr. Natarajan, Athanasios, Saad, Emi, we are going to present cases there. And of course, not only one day, in the large meeting there as well. So we are pleased to have Saad Wahib invite us for this great meeting there. And we are arranging things so that we deliver the program in advance. And I would like to close this Retinawesome 14, thanking everybody for showing up, for discussing the cases, for showing beautiful cases. We are going to be showing as a premiere in YouTube by the end of the day here, within 6 hours. So we are going to edit some parts and present you. And thank you also, Dr. Jorge Rocha from the World Retina Congress. That was his first show, his first appearance in the Retinawesome. And Dr. Subhadra, I cannot tell how good was your presentation and your case, and you gave us such a gift, presenting such nice cases. And as Dr. Lam said, and I will leave with Dr. Lam to close this event now. Dr. Lam, please. And thank you again for all your presentations.
Thank you, Hassan. And it's always a pleasure to take part in the Retinawesome. I think it is even a greater tribute to have Dr. Subhadra presenting her wonderful experience, her many years experience in managing pediatric surgery, her careful selections of the cases, her superb surgical skills, and her dedication to her chore. I think her fellow has already said that she works till 10 o'clock in the evening, like beyond anybody's kind of normal working hours. But yet she still dedicated the same amount of attention. I think the cases that were shared among the groups was also wonderful. And I think the spirit of the Retinawesome is that sharing and the discussions that follow the case presentation has always been the most fruitful and rewarding, at least for myself, to be taking part of it. I think I can speak for everybody that is the benefit for everybody. So I think, again, I'd like to thank Hassan for starting this, and this is number 14. It's amazing that it go on for so long, and looking forward for more. Thank you.
Thank you, Hudson, for having all of us. And Hudson, I think I attended all the 14, I think.
Yeah, it's an honor to be with you. And you know that the Retinawesome started not in the pandemic, just before the pandemic. We've met, Natarajan in the World Retina Congress there, and I watch our lectures, and I found them very interesting. And we have a chat, we have a talk, and then I got to know Vaibhav Sethi, the Sethi family, and we are so pleased to meet everybody there. And so this started with a friendship, and I think it's very interesting when something starts with a friendship that we carry on cases and we discuss freely. And the shape, you know, of Retinawesome this year is a little, you have more discussion and less speakers, but with more discussion on each case. And this is very good. And we are very happy to start, to have started in the pandemics. And now we are going presential in some meetings. And the best thing is that we are together and we plan to do so. And thank you again, Dr. Anita, for being with us and watching Subhadra's cases. And if you want to say anything, you are free, and we will end the meeting.
Thank you so much. This was so lovely to have everyone here and get your feedback, and please do give more feedback so that we can all improve. And it's always the heart, the friendship, which then leads us to the correct path. Thank you so much.
Our honor. See you guys. Thanks a lot.
Thank you. Thank you. Hope to meet you again on this forum.
Thank you, Hudson. Thank you, everybody.
Thank you, Euler. Thank you, Euler.
Thanks, Ever.
From Goiânia, from our city here, Dr. Euler.